Good morning. My name is Obot Isiana-Antiagong. I'm a professor of pediatrics and neonatology at the University of Calabar, a consultant pediatrician neonatologist at the University of Calabar Teaching Hospital. We shall be spending the next 3/4 of an hour addressing the pathogenesis and pathophysiology of hypoxic ischemic encephalopathy. What is hypoxic ischemic encephalopathy? This is a type of neonatal brain dysfunction or disorder that occurs when the brain does not receive enough blood and or oxygen flow for a period of time. It is the consequence of severe birth or perinatal asphyxia. It is usually characterized by abnormal neurobehavior. For example, depressed consciousness and some brainstem and motor dysfunction. Hypoxic ischemic encephalopathy can result from events occurring during pregnancy, labor, delivery, and even post-delivery. We shall now be examining some etiological factors of birth asphyxia that, of course, is a precursor to, or is a cause of hypoxic ischemic encephalopathy. Let's examine first factors in the mother, maternal factors. Hypertension in the mother or hypotension will lead to disturbance of perfusion of the placenta and lead to disturbance in blood flow and oxygen delivery and carbon dioxide removal. Another factor in the mother, toxemia, pregnancy, eclampsia. Uterine rupture or tetany will also interfere with blood supply to the placenta and, of course, to the fetus. Severe anemia is another. Infection, amnionitis, diabetes mellitus, hyperventilation, prolonged and obstructed labor, and vaginal bleeding. The bleed may well be from the placenta, and this will interfere with the delivery of oxygen and removal of carbon dioxide from the fetus. There may be factors in the placenta or the and the umbilical cord. These are such disorders as abruptio placenta and placenta previa, cord compression, and in certain cases there may even be a true knot, a knot of the cord, prolapse of the cord, and knuckle cord. All this could interfere with the flow of blood to the fetus, and of course bring about hypoxia. Abnormal cord insertion, as may be found in velamentous insertion of the placenta, of the cord onto the placenta, and this will also could also disturb the blood flow from baby to placenta, and or otherwise, infection and inflammation of the placenta, fetal-maternal hemorrhage, like I mentioned in the earlier case with the mothers. Let's now see those factors that may operate in the newborn itself. Blood loss leading to shock, obstruction of the airway, CNS disorders, and the depression of the CNS from medications that may be given to the mothers, infection in the baby, brain trauma during the process of delivery, and severe congenital cardiovascular diseases. These are factors that could impair blood flow to the fetus and or blood flow to the fetus and delivery of oxygen and removal of carbon dioxide from the fetus. And of course, after birth, we spotted the factors that may operate. Let's pay some attention now to the pathophysiology. When there is brief asphyxia, what is found is that there is tachycardia. There is a rise in blood pressure, and of course, a rise in central venous pressure. While all this is happening, it's that there is no change in the cardiac output. The earlier responses are the response of the circulation of the newborn to the asphyxiating situation. Also, we find that there is a redistribution of cardiac output. That is the diving reflex, where blood is diverted to those centers or those structures in the body that are helpful in this stressful situation. Birth asphyxia is stressful onto the newborn, and blood is diverted to the brain, the heart, and the adrenals. These are structures or organs which are vital for survival in this stressful situation. Of course, as blood is diverted to the brain, heart, and adrenals, it is diverted away from those structures or organs that are not vital for survival at that time, away from the kidneys, from the intestine, from the molars, diverted away from molars, because those are not vital for survival at this point in time. Despite the hemodynamic changes that we've mentioned, that the diversion of blood to some more vital areas to perfuse the brain, the heart, and adrenals, we see that in the brain, some deep vital structures may not be reached. And this could lead to hypoxic injury. And this could be injury to some subcortical and brainstem nuclei. Aside from these injuries, also other areas that may be injured are the thalamus and the basal ganglion. These are deep greater structures, and of course the pyramidal tract and posterior limb of the internal capsule, which are white matter. This flow chart I find very useful in understand in trying to understand and explain the events that happen in birth asphyxia. With the onset of the insult, we see that there is a redistribution of blood, like I mentioned earlier, to the heart, the brain, and adrenals. At the same time, too, there is an increase in blood pressure, an increase in cerebral blood flow. All these are auto-regulatory mechanisms to keep the system alive. In the absence of oxygen, there is accumulation of carbon dioxide, hypercapnia, of course, hypoxia, and acidosis. If there is not enough intervention to change this situation, these regulatory mechanisms, these auto-regulatory mechanisms are overwhelmed. And what will happen is that the blood pressure falls. There will be a drop in blood pressure. And following a drop in blood pressure will be a drop in cerebral blood flow. And this is the basis of this ischemic brain injury. In the face of prolonged asphyxia, there is a loss of auto-regulation and carbon dioxide vasoreactivity. I mentioned this earlier on. And as blood pressure and cardiac output drops, there is a further disturbance of and a drop in cerebral blood flow, as was shown on the chart. In the absence of oxygen, anaerobic metabolism ensues, and this results in cellular energy failure due to increased brain glucose utilization and a fall in glycogen, phosphocreatine, and ATP. Remember, 36 ATP produced in the aerobic metabolism of glycolysis, while 2 is produced in anaerobic. And you can see that disparity in energy of about 34 ATP. And this is the basis of further disturbances that we are going to see in the course of looking at this subject. Should asphyxia be prolonged, this situation would cause further damage and it will diffuse that damage in other areas of the brain. Earlier on, we are talking about deep structures. Now, cortical structures and subcortical structures are injured, and with greater injury to those neurons that are particularly prone to hypoxic injury. We now need to examine events at the cellular level in the face of continued hypoxia. There is reduced oxidative phosphorylation and reduced ATP production. Recall that aerobic glycolysis yields 36 ATP compared to 2 in anaerobic. The difference of 34 ATP, that's a large gap in loss of energy. The energy failure that ensues impairs ion pump function. This leads to the intracellular accumulation of sodium chloride, water, and calcium, and the extracellular accumulation of potassium and excitatory neurotransmitter, glutamate. This is as a result of the failure of this pump because of the ion pump function, because of this low energy. But all these are functions that need energy to maintain the equilibrium. As energy is lost, you now see that the cell cannot, and there's influx of sodium, influx of chloride, water, and calcium. These have consequences on function. It's important to know that impaired phosphorylation can also occur even during brief asphyxia. But if there is sufficient resuscitative action, further damage could be halted. And this brief, the impaired phosphorylation could cause secondary energy failure, which may occur approximately 6 to 24 hours after the first insult. Impaired phosphorylation can occur during brief asphyxia, and this could lead to secondary energy failure, which occurs approximately 6 to 24 hours after the initial insult. The consequence is cell death would occur. And this cell death could be immediate or delayed, or by necrosis, or by apoptosis. Let's examine immediate neuronal death, necrosis. This may be due to the intracellular osmotic overload of sodium and potassium, and due to failure of the ion pump, or through the effect of excitatory neurotransmitter acting on the NMDA receptors, as well as the AMPA receptors. Remember, we said that there is accumulation of glutamate extracellular in the extracellular space, and glutamate is the primary neurotransmitter in the brain. And excessive accumulation means excessive stimulation and excessive impulse generation. And this could lead to damage through excitotoxicity. Just another word on the subject. This will further bring the perspective. Excitotoxicity. This is a mechanism of neuronal damage in acute or chronic neurological disorders, as would occur in parental asphyxia, HIE, and exposure to intrauterine inflammations. This is mediated, like I said earlier, through that neurotransmitter glutamate. Glutamate is an ionic form of glutamic acid and is the primary excitatory neurotransmitter in the brain. Of course, the signals that glutamate produces are through two receptors, the NMDA and the APMA. This is from here that's through these receptors that nervous signals are sent out. So it is known that in a normal circumstance, a proper function of glutamate with these receptors is crucial for normal neurodevelopment. Hence, brain injury in HIE is due to excessive excitation, leading to cell death. Glutamate accumulates, and this leads to excessive excitation through these receptors, and these excessive impulses are the things that are toxic and, of course, bring death, cause cell death. Oxygen and glucose deficiency also play roles in fetal neuronal injury. I find this chart also very explanatory. It just encapsulates what we've said in the last few minutes. Aerobic glycolysis generates 36 ATP, and aerobic glycolysis is interrupted by hypoxia, removal of oxygen. Anaerobic glycolysis ensues, which produces now only 2 ATP. This brings about energy deficit within the cell, so that there's impairment of ionic transport, impairment of amino acid transport. There's accumulation of glutamate, accumulation of sodium, calcium. The accumulation of reactive oxygen species, nitrous oxide, and of course, the accumulation of glutamate leads on to excitotoxicity. This would directly lead to cell death. But in the case that cell death does not occur, it could lead to the release of some radicals, catalase, peroxidase, and of course, this we know have to be eliminated if damage is to be averted. In the phase of reoxygenation, we may have we now have the release of some other superoxides, reactive oxygen species, endonucleases, phosphatase, lipase, and nitric oxide. This could directly lead again to cell death, or in the face of intervention, you find that there will now be neurogenesis or sprouting or sprouting and cell repair. On the other side, there may be activation of sentinel systems, like increase in PRP1, which we know is crucial in the repair of the DNA. And of course, mesotrophic factors, which also help in repairs. I hope that this chart has put in perspective what we've said so far. There's delayed neuronal death, apoptosis. This is secondary to uncontrolled activity of enzymes and second messengers. Second messenger system in the cells, e.g., calcium-dependent lipase, caspases, proteases. Derangement of electron transfer at the mitochondria, production of free radicals, leukotrienes, nitric oxide, and an exhaustion of energy stores. Remember that this is delayed as against necrosis, which is a more immediate event. All these substances produced are injurious, and it's just akin to sentencing the cell to death in a slow process. It certainly will bring about the death of the cell, but not as immediately as would happen in necrosis. This diagram too helps to explain what we've said so far. There's perinatal hypoxic ischemia that's leading on to primary cerebral energy failure and reduction in cerebral blood flow and oxygen, reduction in high energy phosphorylated compounds and brain acidosis. Resuscitation could result in two ways. If it's not successful, probably immediate neuronal death to the cells that may have been very badly affected, or there may be some resolution of the hypoxic ischemia with normalization of cerebral metabolism and restoration of energy reserve. And post-treatment, post-resuscitation treatments is then instituted successfully, no brain injury, but should not be successful, then we have secondary failure of energy with derangement of those functions, reduction in high energy phosphorylated compounds, and of course, it could end up in delayed neuronal death. Reperfusion. Following resuscitative efforts, as blood supply returns to previously ischemic tissue, injury may be exacerbated through the formation of excess reactive oxygen species, superoxides, hydrogen peroxide, singlet oxygen, and hydroxide compounds. These are toxic substances. These are substances that are injurious to cells and that are produced on account of the injury that may have been caused before. This would cause further injury. If the ability of the scavenging system is overwhelmed, scavenging system to remove the superoxides and all those harmful substances produce hydrogen peroxide, cyclinate, oxygen, and hydrogen compounds. If the ability of the system to scavenge, well, the body has a system to remove this toxic material, but when too much is produced, the ability of the body to remove it is overwhelmed. Being overwhelmed, these substances lead to damage, and damage is done to lipids, proteins, nucleic acid, and the blood-brain barrier. As a result, an influx of neutrophils may occur. And together with activated microglia would produce injurious cytokines like interleukin-1 beta and tumor necrosis factor. And these will be responsible for the damage to the brain cells. Again, this goes to demonstrate what we have said to a large extent, and we'll come back to this when during the next lecture while looking at the remedies, treatment. The insult leads to primary energy failure in minutes. Of course, the primary energy failure leads to sodium overload, calcium overload, excitotoxicity. With some recovery, there's reperfusion, and then that could be that leads now to a second phase where reactive oxygen species produce. There's calcium overload, there's nitric oxide production, and secondary phase of injury occurs hours to days after the primary, but 6 to 24 hours after the insult. And this could lead to mitochondrial dysfunction and caspase activation. And of course, ischemic, hypoxic ischemic brain injury. You can see that immediate necrotic cell death could occur shortly after the initial insult. And there will be delayed apostotic cell death following the second phase of loss of energy. This chart really mentions the interval within which therapy, which is the recommended initial therapy now being therapeutic hypothermia, should be instituted within 6 hours of the initial insult. I want to thank you for listening, and I hope that this encounter has helped us understand a bit more, that we'll be willing to address questions at the end and clear up any gray areas. Thank you once more.